The topic I would like to share some information with you is obesity treatment targets effect of physical training and dietary intervention. I realize that the title is too cryptic for this hour of the day, and I say just let's simplify. Any role for exercise in CKD, because I know I will skip the part of diet because Enrique said many things about it. So do you think that we have enough knowledge to consider the role of exercise in patients with renal disease? I'm patient with diabetes. So there is no need to comment to you the general benefits of exercise. There are too many, and this is just a simple list of the things you can do with exercise and you can improve. But still we don't know if these apply also to exercise, and these apply also to CKD. And there come the problems, because how may I exercise in CKD patients? We don't know. There are many theories, the amelioration of insulin resistance, weight reduction, etc., but we don't know. And then which CKD? Is the same a patient with polycystic disease, lean, without proteinuria, than a patient with diabetes, obese, and 2 grams of proteinuria? We don't know. We always put CKD as a whole, and it is not it's a very heterogeneous disease, as it was shown before. And this is the most important problem. Which outcomes? Just metabolic outcomes and renal outcomes. And what is to define, how to define a renal outcome? This is a complex issue. And if you want to move to the exercise part, which type of exercise? Aerobic, resistance, both? How frequent? How intense? And for me, that we are now working in the lab with this topic, the adherence is not just go out and walk, swim, or cycle, just the adherence. Every time you need to start an exercise protocol, you need to start in parallel an adherence protocol, because it's very difficult to do it without considering this issue. And you will see that in most of the studies we are reviewing now, adherence is missing. And if you don't consider adherence, success is not going to be at the gate. Just trust me. Well, when we talk about exercise, not in terms of general health improvement, because we're talking of patients with CKD, we try to focus a bit more on renal health benefits. Which CKD? I think that if exercise, just a personal opinion, has a niche, an area of benefit, will be this large group of patients with obesity, metabolic syndrome, diabetes, overweight, or insulin resistance, call whatever you like. Because we know very well that metabolic syndrome is a risk factor for CKD, that obesity is a risk factor for CKD, that obesity plus metabolic syndrome, the so-called metabolically unhealthy obesity, is a risk factor for renal disease. And also we don't know that obesity and metabolic syndrome accelerates the evolution of patients with established CKD. So it's not a standard pandemic. This is a study I like very much from Kurela. This is a sub-study of the ARIC group, and they follow up patients without diabetes for a long time, and they found, in plain and simple, the higher the number of metabolic syndrome traits, the higher the level of insulin resistance, as expected, but the higher the level of the risk for CKD, for incident CKD. And this is a recently published study from the Neptune group, and they found that if you are obese in the adult life or in children, the obese have a worse response to glomerulonephritis, or different types of glomerulonephritis, to treatment. So, again, not exercise to improve physical parameters. No, just exercise to treat the things we know that are risk factors for renal disease. Exercise training can diminish all these risk factors. You know that these are risk factors for CKD. Do you think that we can apply these to renal outcomes with exercise? Let's see. That's what we think, that if we treat by exercise these risk factors, you can prevent or slow established CKD. So exercise could be considered a way to reduce metabolic syndrome, which in turn may help preventing and treating. I think this a bit more on treating, because preventing is much more difficult to prove. And here comes the real problem, because which renal outcomes? There are two major renal outcomes: GFR decline over time and proteinuria. Proteinuria is a simple outcome. You measure proteinuria, you diminish the number of the proteinuria of albuminuria, and that's okay. But what about GFR decline? And this is a problem that is neglected in many clinical trials. This is a group of patients with accelerated GFR decline. They are losing 5 milliliters per minute per year. Let's suppose that we can do something for them with exercise or with a drug. And you reduce renal function loss by 50%. You are moving from -5 to -2 milliliters per minute. This is a huge improvement in nephrology, but it's a small number. How many patients do you think you need to reach this difference? And this is a statistical problem, and this is a problem we have as nephrologists. For example, there is another problem, that the evolution of GFR, as Enrique showed, is not uniform. And if you're going to act by exercise in metabolic syndrome traits, you're going to influence in two ways GFR: an acute change and a chronic change. This is the study of the Mario Negri group, and they are patients with hyperfiltration and diabetes. If you treat with blood pressure control, glucose control, in the black mark is those that ameliorated hyperfiltration, and those in which hyperfiltration was ameliorated were the group with blood pressure control and glucose control. And that showed, I don't know if I can see it, no. This group, those with ameliorated hyperfiltration, showed an increase in insulin sensitivity. This is what Enrique showed, that if you treat by bariatric surgery, meaning reducing a large amount of weight in a small period of time, GFR will decrease. The same as if you treat blood pressure, glucose, etc. So you need to expect, if you try to plan a study in that field, to divide evolution in two parts: an acute change and a chronic change. And it has been shown that the better the decrease, if you can say that, the deeper the decrease, the smooth, the slow in the future. So it's like losing GFR early can be nephroprotective in the long term. It's a counterintuitive thinking for nephrologists, but we need to remember that the history of hyperfiltration has more than 50 years, and we never understood possibly well this idea. If exercise is working, you expect that people without, in the control group, will have a faster decline. So we need to be a bit schizophrenic, thinking about metabolic outcomes with exercise and renal outcome with exercise, and they both must go together. If you don't, and you are not able to reduce weight, for example, you won't be able to reduce possibly GFR. Which is the available evidence? Sorry. Well, it is not quite impressive, I must say. We are currently doing a review in the field, and we divide these studies as prospective studies and clinical trials. We found 17 studies. We are doing that with Raúl Morales, the physiotherapist is working with us in the lab. And this is 17 studies, not randomized, 500 patients more or less, CKD 2 to 4, short follow-up, 3 to 6 months. And they usually use aerobic in all people and resistant in half of the patients. No adherence support was observed in more than half of the studies. This is important. Look at the column of no significant changes. Most of the studies didn't find BMI changes blood pressure changes, dyslipidemia changes, or changes in glycated hemoglobin. So you're not going to find anything in the end, I think. And regarding GFR in general estimated or proteinuria, no major results were found because possibly as a consequence of not finding changes in metabolic syndrome parameters or the short term, we don't know. Clinical trials, many of them with very limited number of cases, because I think it's almost impossible to calculate the end of these studies unless you do in advance an exploratory study. 16 studies, CKD 2 to 4, follow up at least some with 12 months, aerobic and resistant training in few, no adherence report again in more than half of the studies. Sorry. Again, no significant changes in metabolic parameters. Perhaps exercise was not working, perhaps the dose of exercise was not correct, perhaps the length of the study, perhaps the adherence, we don't know. But this is something we need to consider, because it's very nice to talk about exercise, it's healthy people running, but these are not healthy, and we need to find something a special outcome to look after, not just go on running. Again, in these trials, no major results were observed with proteinuria or estimated GFR. So, why did that happen? Possibly the low number of patients. Another aspect that is important if you work with this physiotherapists, they will always tell you step training or one for all. It's the same to give a very tall man a type of exercise to a thin woman. Perhaps this tall man was doing rugby when he was young, and the woman, of course, not. What about the selection criteria? In which patients are you going to expect the effect? Follow-up must be at least 1 year or 2. Adherence is crucial, and if you have scarce weight variation, it means that something went wrong. So, in any case, all studies have shown improvements in physical parameters, no adverse effects, but the effect of renal outcomes is still to be discovered relating to exercise. This is why we try to design a study that we started last week in the Hospital Universitario de Canarias. It's called XRED, Exercise in Renal Disease. It's just an exploratory study to find problems. Exercise in patients with CKD plus metabolic syndrome will improve weight and parameters for metabolic syndrome. This is our hypothesis. And this intervention could eventually improve renal outcomes, proteinuria, and renal function loss over time. We will include patients with CKD of whatever cause, but with metabolic syndrome, established metabolic syndrome. Clinically stable, and all patients will undergo a step training protocol, so no one for all. We will try to include 50% women and 50% men, because it is expected that the effect of exercise is not going to be the same in women. Renal function will be measured, but you already know that, by the gold standard, the plasma clearance of aerosol used in DBS, and we will evaluate proteinuria and albuminuria. The step-tailored treatment, we will define a priori patients as sedentary, those with moderate activity, and those with daily activity. So those with a sedentary history will receive aerobic exercise 30 minutes 5 times per week, plus strength exercise lower than 15 repetitions with moderate intensity. Those with histories moderate activity will start with a different scheme, aerobic exercise 5 times per week, strength and moderate intensity. And those with daily activity will start with the stronger protocol. Some changes can be implemented based on the adaptability to exercise. After a month, muscles are different if you're doing an exercise, and we will check the response based on the change in BMI. Well, don't look at that. It means that every time we will try to increase, if possible, the type of exercise, not one for all. Adherence, how to do it? Well, telephone calls every week, the 4 months, I think is crucial. And every patient will be provided by a bracelet activity tracker that can be controlled by a telephone. And of course, we will evaluate the response with changes in metabolic syndrome parameter and weight. In case we have problems with adherence, we will increase by the protocol by increasing the intermediate visits, talks reinforcing the importance of exercise in these particular patients, and we will increase the telephone calls. This is the protocol. This is just a 6-month protocol. We do IOXOL at baseline, 3 months and 6 months to expect a GFR decline related to BMI changes and metabolic syndrome changes. We will take analytic anthropometry, and we will start from the day 0 the exercise protocol and the adherence protocol. What do we expect? Well, if everything goes well, we will expect an early reduction in GFR, and we will try to analyze this reduction with the reduction in BMI, metabolic syndrome parameters, insulin sensitivity, and inflammatory markers. And we expect in those with a proteinuria diseases a reduction in proteinuria. So, I'm sorry to conclude that the evidence on the impact of exercise in patients with CKD is very weak, and we need to do studies in the field. We need to identify the niche of exercise in CKD, possibly the patient with metabolic syndrome. To do what? To prevent CKD, I'm not so sure. It will take a long study. But to slow progressions in patients with established CKD, I think it is important. Which outcomes? Of course, both metabolic syndrome and renal. And yes, we need long-term studies to say that these that are lifestyle interventions that are very nice thing to talk about, but then when you go and evaluate that, you see that the evidence is weak. And thank you very much.
Thank you very much, Esteban. We have a question in the audience. I just need. Will you give me the? Yeah.
Thank you very much for a very interesting talk and very interesting trial you're running. Are you doing any acute bout of exercise measurements to see the exercise-induced difference in organokines and also the exercise-induced hyperkalemia that is well known?
Well, yes, the patient will be followed, and we will measure many things. And every time we do the IOXOL, we take samples, and we think. But we don't expect, they are not severe CKD. They won't be not severe CKD patients, but we will take care of that.
Okay, because it could be quite interesting to see a study, an acute study within the long-term study, if their profile changes over time in response to the exercise intervention.
We need to do the first study as an exploratory analysis because it will be the first step to calculate any power to see differences. But this, it would be impossible to start with a randomized trial, long-term study. It will be suicide.
We don't want that.
I have 2 questions from the chat. The one was actually also related to the hyperkalemia risk that you already answered. And then there is also a question from Biasolo Natalie. Which kind of physical exercise is the best? Is it endurance or is it low intensity, like 70% max heart rate, or interval training such as fartlek or a team sport like soccer, for instance? Have you any considerations about
I would be a magician if I had the answer. There is no evidence saying this type of exercise or the combination all the time. We know if you, Raul will show you tomorrow that we can have some hints from the DPP, DACing, and other studies on exercise and preventing diabetes in pre-diabetes. We follow that studies, saying that exercise, aerobic exercise 3 to 5 times a week is okay. But for sure, we don't know because not all the patients are the same. We don't have the answer for that yet.
Okay. The next question was related to that you told that there was no significant outcome by mean aerobic exercise. And there's a reference to Professor Peter Krustrup, who suggests interval training. So that is good for bone and muscles and heart. Is that your opinion as well?
It may help. It may help. Now we need to see. I think that every type of exercise you select must be tailored for the type of the patient, of the characteristic of the patient. But this type of exercise can help. Yes, for sure.
There's one more.
Well, thank you very much. This is very interesting. Do you plan to evaluate their body composition, or do you only look at the BMI?
Yes, we are planning to, and we do some kind of specific echography to identify muscle and fat and the body composition, yes, to see the changes.
We have one more question.
All right, when we have patients with proteinuria, we often treat them with ACE or ARB or SGLT2 inhibitors. But do you think when we reach maximum doses of these drugs, we should be more focused on treating obesity, for instance, with surgery or GLP-1 analogs or maybe exercise?
For sure. Absolutely,
Yeah.
yes. Once you reach a result with the best you have, you need to start other things, and exercise has been unexplored.
And it's because we think weight reduction will reduce hyperfiltration.
Exactly. But
yeah.
In any case, you need to start this type of lifestyle intervention when the patient is stable. You can add a patient with lupus nephritis with a crisis of, you understand me. You need a patient must be stable and reach the top of the treatment he tolerated and you gave to him. And then you can see if this is helping or not.